So welcome to the webinar about the cortical struts augmentation technique. Myself and my colleague Siegfried Hölzer from the Weiter Campus and Development would like to demonstrate you our cases with the cortical struts and focus on long-term results using that technique. We now overlooking 3 years of revolution, as we call it, or evolution. This technique is actually based on the classical bone blade technique by Professor Khoury. The problem was that, of course, the Khoury technique had a severe surgery. You didn't have the material handy whenever you need it, and you couldn't use it in all that indications. And so we changed a little bit about it. So it's actually an evolution of the Khoury technique. When we look at augmentation materials, we will see that there are different materials on the market. All of these materials have been used quite frequently and with a lot of success, and all of them have their special indications. They have cases where you can use them with a benefit, and of course in some cases they will have a disadvantage. So we're overlooking autografts, allografts, xenografts, and alloplastic material. So we're actually going from the human being over animal or plant derived materials to synthetic materials. Now, to see the benefits, for example, we see that we have, when we place an implant in an immediate socket, and we would like to augment the vestibular part of the alveolus. The thing is, what do you want to achieve? So to maintain the third dimension beside the implant is all covered into nice autogenous bone. We would need something that, of course, is most stable. Is we want that soft tissue to be supported, if we want the bone to be there for the next decades, of course, therefore we want a material that is not resorbing, that not needs necessarily to be loaded in order to keep the functional height, and therefore in this indication, for example, we would use xenograft material, because that is ceramo-osseous, non-resorbing, and it gives you the maximum stability. So in this indication, of course, this material, xenograft material, has a big advantage, of course. But if you look at all those materials direct into contact to our implants, we will see cases where you see that the autogenous bone is resorbing due to an infection in this case, but you see that the xenograft material that has been put directly to the implant just sits there because it's not vital at all. Okay, just sit there, it is infected, you have to remove it and re-augment it, but it's not the best material to use in direct contact to your implant. So what we would like to do actually around our implants, we would like to copy nature principles. So around our implants, we would like to have the most vital material, because vital material, bone material, can react to stress. It can build, a stronger bone. You can modify it. It will nourish your soft tissue, buff it. So there we have the most vital around the implant to have a long-term implant success. The other thing is on the outside, like nature will do that. We want something very, very stable, non-resorbing. So in the body, it's like this, that the body builds a cortical bone, which is not very vital, but it's very strong and non-resorbing on the outside. And it has autogenous bone on the inside, which is very vital and can react to all kinds of influences and can regenerate. So in order to copy that, we were looking for an augmentation technique that also gives us a cortical outer side, and that is very rare if we overlook all the materials. If we look at bone augmentation procedures in localized defects, even back to the Jomi publication of 2009, we will see that bone blocks had a gain of approximately 4.4 millimeters, and in nearly all the cases, no further augmentation was necessary, of course, as we built up as much bone as we needed. And we had a rare complication side because it's all it's very nice to handy, and we got a lot of stuff to put there. So even if we had a complications, you will not lose it all. If we're looking at bone particles, they had only a gain of 2.6 millimeters in this study. No further augmentation was needed in 75%, because if you use particles, you have more resorption, of course. And we had a complication in 30% of the cases, because when you had an opening up of that defect or membrane problems, then you will lose a great part of the particles, because you get an ingrowth of granular tissue, and you lose quite a lot of it. So we have a higher complication rate. If we look at the 3D augmentation, the classical Khoury technique, of course, they were taking a cortical blade from the ramus ascendens of the ramus and transplanted that to the site wherever you need it. So you had to open up another site, you had to take out that cortical strut, you had to thinnen it in your hand, you had to split it in your hand, and then you had to move it to the site where you need it. And of course, sometimes if you didn't get enough material from that site, you even had to open up another site to get enough bone plate to restore, for example, severe defects. So that is the classical Khoury technique, which then healed for 4 months, and after 4 months you had enough bone to place an implant into it. And if you don't place it after 4 months, you have, of course, a resorption taking place again. So the implants should have been placed after 4 months of building up that bone. So we see that, of course, Khoury showed us that you have to build up a space. We're transplanting space, so you have to build a biological container which consists of cortical bone to copy the nature principle, and inside you will fill it with a particular material. Of course, you could use autogenous bone, or you could also use allograft particles. And therefore, because you have got a container which is filled with blood and it's filled with particles, target cells, you will have a full renunciation of that container. And when you open that up and you have a very solid container, which you see when you place your implant, you can be sure that this will be vital bone, because otherwise this would have not been reconstructed. So the Khoury technique, lesser Khoury technique, always needed a second surgical site. You had to open up another site, which is quite a severe surgery. You had a longer surgery because, of course, first you had to take it out, you have to prepare the bone block, you have to thicken it to make it even, to split it. You have to close that wound, of course, again. And you have to be very careful because you've got a higher risk. The quantity is limited because sometimes you have to open up both sides if you need another strut, or if the jaw is so much resorbed that you can't take a big plate out of it. You have a higher complication rate because all the complications that will occur using taking out the bone block, like bleeding, like nerve lesion, like soft tissue problems that might occur. All these complications rate you will not have if you don't have that second surgical site. You have a high learning curve. It's a very nice technique. We've done it for years. It's a very successful technique, but it's not easy to do. You have to train that. You have to be able to treat the complications. So it has a high learning curve. It's a very sensitive method. And of course, the complication management should be you should be able to do complication management. So you have to cope with nerve exposed, you have to cope with intra-osseous bleeding, which you have to cover. So you have to be more of an advanced surgeon than just raising a flap. But what about resorption? So very interesting is if you look at that, that nearly all the studies shown don't tell you about the resorption after the placement of implant. But if you look at Khoury techniques, despite they're very successful, like here of a very nice, very talented colleague, Jochen Tunkel, showing the classical Khoury technique, you see that you get a nice amount of bone, but you have resorption. You see that the screw head is sticking out a bit, and you will have a resorption taking place. And going on from that, if you look at the studies, you will see all the studies about the stability of natural bone blocks stop at the time of implant placement. So there are really a lot of studies. There are only 2 studies showing what happens the further resorption after implant placement. Nobody has been taking care of that, and that shows that you will have an extra amount of resorption after the implant is placed. So the question is long-term results. Is it favorable to have also a sort of a natural material, also something that could copy natural principles, but will be more stable if you look at long-term resorption? So we've been looking at allografts because this is a material that has been documented in Germany in classical surgery since 1957 very successfully. It's a material that is on hand and where you can design all the shapes you would need, and therefore we designed the cortical struts in this size that has been proven to be a very good size using the Khoury technique, which is sterile for 5 years, and it's just lying there in your drawer whenever you need it. So you always got a piece of bone or wall of bone when a wall of bone is missing. And that is sometimes if a splitting has a complication or extraction has a complication, or in case of peri-implantitis treatment where you need a wall of bone that is stable to resorption, this is very handy to use. Also, severe defects that we treated using hip augmentation can now be reconstructing using bone plates. You can reconstruct them using these plates and build a biological container which you can then fill with autogenous material or allograft particles and restore that easily, and place your implant after 4-6 months or longer, because a cortical strut from allograft material will be very, very stable and not be resorbed as the classical autogenous cortical plate. There are a lot of studies now going on, as you see at this Quintessence publication regarding now allograft materials. There are a lot of different shapes of allograft materials being used. They are going more and more on the market. In the United States, of course, it's used very nationwide, and they're very popular and very successful use by dentists and oral surgeons. But in Germany, it now gets to the market. Now to show the video how the cortical strut is used. We got a cortical strut cutter, so you could cut that cortical strut, not harming your hand or taking a round saw in order to be careful with it. It's very nice to cut like a piece of paper. You just measure the dimension you need of the cortical strut. For example, here in this case would be 15 millimeter. Then you just place that, so you got a measurement on that cortical cutter, and then just cut it very easily without having the danger of cutting your finger or flying the bone through the surgical room. Then you can put it on that, and you can drill for the holes, which is also very easy to do there. Then do it in your hand. 2 holes will be good enough. In this demonstration, there are 3 holes. We mainly only to do 2 holes, and then we will fix that with an osteosynthesis screw with a 1.0 or 1.2 diameter. We use steel screws, not titanium screws, as we take them out anyway, and steel screws are more rigid, are stronger, and there's no danger of breaking them. Then we round the edges using a diamond burr. We fill the gap, the desired gap. We build up the gap we need, not for the gap we hope. We build up exactly what we need. We fill that with allograft particles, spongy chips. Cover that with a Jason membrane, which is a pericard membrane, which has a standing time of a few months. heal for 4 to 6 months, in the mean 6 months, and then you can place your implants. You see cases like this where, of course, you will know it is very difficult to do some augmentation. You will see that that there's a very thin bone. Splitting would not be the favorable option on here. So you see that this is very very thin here and very thin here. So of course the splitting might break off the bony wall. In these cases, of course, augmentation with the bone wall is something very easy to do. We just augment the bone where we need it. So that means you don't have to do the augmentation all around the jaw, but just where you want to place your implants. So you place it in the gap you need. You fill that with autogenous bone chips, or with allograft spongy bone chips, which we use regularly, and fix that with osteocetesis screws 1.2 diameter. We cover that then with a Jason membrane, a pericard membrane, and if you have very thin tissue or want to improve the soft tissue healing, we'll put another layer of a fibrin membrane on top of it to have a good wound healing, to have a safe wound healing, and to improve the healing. It gives you just a better result. You see here exactly how nice the bone heals. You see nearly no difference between the gap bone and the plate. It's disappearing, it's rounding, and you see that the screws are still in shape, so there's no resorption taking place. So there's a slower turnover, of course, of allograft particles, which here seems to be of an advantage, because if there's a slower turnover, it means there's more stability and there's less resorption. And in the outside cortical plate, we don't need vitality and resorption, we need stability. In the inside, that's where we need vitality and turnover. Here again, you see a very nice picture of how it looks. How nicely the bone heals. So you get really the bone you build up. It's looking great. See, you can't really see where it ends and where the blade starts. So that's a very, very nice result. To show you a cone beam CT, just to prove what really is happening, what's very interesting to see is that the original cortical line is disappearing. Here you see the plate. Also here you see the plate, and here you see the original bone. The cortical is disappearing. That's also a sign that this disappears, that there's a turnover and there's an interaction, that the original cortical outside is transformed. And that's why we don't decorticalize the bone before we do augmentation, like some schools recommend, and we will not perforate the cortical bone for nutrition or else. We just leave it like that, as we learned it from the Khoury technique, and this really works, as you see. Otherwise, there's no reason why the cortical line should slowly disappear. Also, in this case, you will see that there's nearly no cortical visible anymore. And very interesting also is that you see that is the plate, and following the plate you see a very dense line. So the bone really takes the information and it transforms to really a copy of the natural principle, which we found very amazing when we first saw that in a cone beam CT. To show you the classical case is, of course, the mandible posterior. That's a classical case, also a very good case to start with. We got a triangular shape because we got the resorption very thin at the top, and it gets wider at the bottom. So we place the plate in a distance to the original bone, the distance on the planned implant. So if we want to plan the implant 3.3 or 4.1, and we want to have 1 millimeter more left and right, of course, we will place that in a 6 millimeter distance. So that is that we exactly build up the geometry and the dimension we need. And this is one major difference to if you, for example, use a sausage technique with a membrane in particular material, because this will also give you a round shape. You can't really construct a square shape or a nice even shape. You can't design the geometry, and you hope to get the most. You over augment in most cases to be sure that when you place the implant you will have enough bone. So here this will not resorb, so this will always be the outer line of your augmentation. So then we fill that with allograft particle materials. We really round that blade. We put it all around the particles to make a round shape, to leave no sharp edges. And very important, of course, is that we will round the sharp edges of the cortical blade, and we leave out, here's a nerve exposition, so we leave out, of course, we don't want to have any contact with the nerve. And then we will cover that using, again, the membrane, the fibrin membrane, first pericard membrane, then the fibrin membrane, PRF, which is very easy to do. It's very nice to use, and it improves. We got the clinical impression that really improves. It boosts the wound healing. Patients tend to have less swelling, less pain. You will see a far better looking wound. So that's a very, very good experience we had with that material. So to do some histology to prove what actually happens, we did a maneuver that we went to take the histology, went through the blade into the bone to exactly look at the transition zone of the blade to the bone where the gap has been, to see what happens here. And that usually hasn't been done, because if we will only take the trephine only here, we will of course find whatever we put in here, but what interaction happens here, what happens to the contact zone of the blade to the material we filled in. And that was very interesting, and we did some histology on that. With Professor Dr. Smets and Dr. Hahn, University of Hamburg, and they did some very nice histology on this bone to show that if you look at an allograft particle into this bone, you will see in the magnification here, that's the magnification of that you will see, of course, that is the bone particle, the allograft particle. You will see, of course, empty osteocytes, non-vital osteocytes, but right next to it, you will see vital osteocytes containing a blood vessel, and that is de novo autogenous bone formation. So you see those particles are integrated completely without no separation of soft tissue, granular tissue, or else. So they are perfectly integrated and give a lot of stability, and you still got the vitality of the de novo bone formation. If we look at the bone blade, and that's also very interesting, if we look at the bone blade, then you will see that, of course, you got vital osteocytes of the de novo bone formation. So you see a vessel inside the osteocyte. And then, of course, this is the bone blade. You see no separation. It's totally integrated. And, of course, there it's non-vital osteocytes, because in cortical bone you will not find a lot of vital osteocytes, but that shows you that this is very stable material. So the outside is very stable, very natural, very non-resorbing, and the inside gets very vital. So actually we achieve what we tried to achieve, and this is the histology showing that we are on a good way doing this. So you see here now the result that we have starting from a gap out of nothing. We restored a nice cortical bone, so we restored the cortical outside and we restored the autogenous inside. So starting from there, which is a 7-8 millimeters gap, to there, we achieved a nice result where you can place easily a 4.1 strong BLT implant and still got enough space left and right. So that's a nice nature identical augmentation procedure. Also in severe defects, like if you would look at this defect where you see there's a huge bone loss, and of course we have to augment this. You see there's a severe bone defect, so we got no ridge left, and of course we will have a sinus problem in that aspect. So also here we build up the bone, and you see you can build up a vertical dimension with the bone plates and the lateral. So wherever you need the stability or the resorption stability or the container, you can use it. You can use it on the vestibular side, you can use it on the top, you can use it on both sides. As long as there is some space for vascularity to get into that container. Because you shouldn't build the coffin, of course. Everything inside a coffin would be dead. So we always build a sort of a C shape, so one side will still be open. Then again, we fill that with allograft spongy particles and mix with venous blood or with PRF. In the standard procedure where we use just venous blood and put a PRF membrane on top after we cover that with the pericard membrane, as we mentioned in the last case. So this, of course, will heal in 6 months. You see, we had to do some augmentation here vertically and laterally. And after healing, you see again, looking at the cone beam CT, you see again, this is the cortical plate, still perfectly in shape. And you see again this new dense structure forming, okay, starting at the plate. This is amazing. And you see that the original cortical bone slowly disappears. So you see again a nice result where you see the bone plate is disappearing and you got a nice wide ridge and a nice height to place the implants in. And you can also do that in even more severe cases. So if you look at this case, you get a huge defect, so the ridge is missing, and you're on the bottom of the sinus, and the sinus is exposed already. So in order to augment this is very difficult to augment because you need a lot of vascularity to come, you need some stable augmentation, and you need, of course, stability in that augmentation, and that might be not enough for even a reinforced membrane. So what we did here, of course, we're using that perforation to perform the sinus lift. And then simultaneously we'll reconstruct that wall using a bone plate. So we use piezosurgery to make a nice line in the bone to put in our cortical strut, as you see here. So we'll cut a little line in it. So we can place the strut and then choose about the right size of it. So first to plan here, because of course this will not be able to be covered and it will be in wrong angle. So we decided only to build up the bone on the first side here, and then put the plate in here and fill the rest after. See, that has been the sinus lift. And then fill in the rest with allograft particles. Okay, so from there to there we build up the whole stability, and now this container, of course, will have a stability, as this is not soft, even if there's some movement on it by the interim structure or the provisional the patient has, or by muscular tension or whatever. So we can be sure that the design we have will be stable and will be still there when we open it up back up. So then you see the screw still here, so there's no resorption taking place. The screw is still in place. There's no resorption, and now we can place in 3 implants, which has been nothing. You've seen it. This was all gone till the sinus floor. So all this is augmented bone. You see the nice integration of the bone plate, and the nice width and height we regenerated just by using allograft particles and a bony cortical strut. Then we have been a 2-layer closure. So we left that open for free granulation in order to make it easy to cover it. So we get more keratinized soft tissue on the outside. This is, of course, connective tissue, which we leave open. So we just move that a little bit to create a wider reach of keratinized gingiva and to have keratinized gingiva on the outside of our implants. So we don't have to perform another plastic surgery after that augmentation or after placement of implant or when we uncover the implants. So then you see it heals nicely. Implants are also overlaid by bone, so the bone even covered partially the implants, which we had to take partially away, which is very interesting. So this seems to be very vital. Then we placed, of course, gingiva formers and again did an apical reposition flap to even improve the keratinized tissue around our implants. After that, you see that we, after healing, a very nice healing of the gingiva, we placed individual abutments made from zircon oxide, and you see that we now got a very nice keratinized zone of soft tissue around our implants to have very stable conditions also long term. The final result, you will see that we got now nice crown placed, that we got a normal ratio of crown to implants, and you see the severe defect has been all augmented vertically and laterally in a severe case and without a lot of vascularity coming from base. So that shows you the potential of this technique. So starting from there to the augmentation, sinus lift procedure and bone block. See, that is the sinus lift augmentation simultaneous with the bone block augmentation. To the final result, you see you got full length implants in there with no problem in a standard procedure. And the soft tissue has not been ruined like in most severe augmentation sites. Also, the vertical dimension, of course, can be adjusted if you need some vertical augmentation. See here the bone starting go over here. So we need some vertical augmentation. So we can use the bone plate as a bridge to keep up the soft tissue and create a container which is stable, and then can augment that to have a hair ridge and some aspect about some material about the nerve. So we show a video now showing you how this vertical demonstration is done. Very important is that if you look at the procedure, most colleagues think that it's difficult to cover an augmentation site in the men. That is only because there's a technique that is unknown colleagues, which is prolonging the lingual, and that is without a periostal cut. Most people don't know that you got very not strong and very weak connective tissue, which is between the lingual mucosa and the muscle on the bottom of the lingual side. And when you just pull and push with a brushing motion that flap, you can easily prolong the flap on the lingual side with no pain and no problems for the patient to cover easily the augmentation side in the mandible, 2/3 from the lingual side and only 1/3. Here you see the procedure, see? Only 1/3 from the vestibular side. Therefore, you don't have to move the tissue back or perform vestibuloplasties as much as you would have if you prolong the vestibular flap so much. We always take some autogenous bone using a safe scraper. This is a small safe scraper called micros, to get some autogenous material, which you can use as target cells. You can also use only allograft particles. This is, of course, also a matter of the budget the patient has, of course. If we can have a free choice, I would rather take only allograft particles because it's the easier maneuver and the shorter surgery, and easy to control how much you have and how much you need. So you see here that we will make a trine of the cortical blade in order to decide it should be like a plank on the ship. We'll see how wide and how long it should be. Then we drill for the holes on the outside. Fix that using osteosynthesis screws vertically. First one screw, fix the blade, then drill the second hole, and then the second screw. In the posterior, we will need a small adapter for the screw, of course, because with a straight hand screwdriver, you would not be able in this region really to easily place that screw. So just make a vertical screw. And now it's very stable. And then we will place a membrane on the lingual side. First we round the edges using the diamond burr. Really do that carefully that they have no sharp edges, because we all know also from other augmentation procedures that soft tissue does not like sharp edges. So we round that. Then we will place a pericard membrane on the lingual side. First we put it in there dry, so it's easy to place and easy to stand there. Some pressure lingual against it. You're able to fill that. Okay. So, going to the next slide, we see that this has been the augmentation we performed. You see there was a defect, and you got some augmentation in height, which you see even here, how much augmentation you gained within structure. So you really got a nice augmentation in vertical height in a very safe maneuver. Also here the cone beam CT to show you the difference in bone. So you see from there to there, all one very vertical gain. So we can easily place then our implants. One tooth still has been lost after that procedure, but the implants and the bone augmentation is very stable. 1 year post-operatively, you see that there's very stable bone. So we got enough bone above our nerve to place the implant, and it's very the density of the bone cannot be differentiated from the natural bone. So you see that this is not like a dense procedure of a sinus lift or else, as you see here, but this looks like a very nature identical bone augmentation. In another case, we've done also a lateral augmentation. You see again how nicely the tissue heals using PRF material, and you see how nicely the bone plate integrates into the side, so nearly no difference between the gap and the actual bone plate. The screws are still totally in place, so there's no resorption taking place in this aspect. Then 8 months after placing the implants, you see still that the bony side looking good. You see that it gets more and more dense, the material, and overlooking the years, you will see that 2013, 2014 after implant placement to 2016, you will see that actually the cortical line gets very dense. See in this aspect, for example, so you really got a cortical regeneration on the top. Okay, see it gets denser and denser, and absolutely bone stability of what you augmented. See, that is natural bone changement in the same system, and here you see that this is a very stable bone. Also in the cone beam, after 3 years of augmentation now, you see that this is fully regenerated. It has a cortical outside. It's a very stable bone augmentation in width, so it's very, very stable because of that very slow turnover. Now, of course, if you open up a surgical site and you have to make something fit and adjust the shape and the length of material, this is very time consuming, and also it prolongs the surgery. So again, we gave some thoughts to how can we make this more plug and play and easier for a colleague to use, not to be having to adjust that intraorally so much and prolong the surgery and to mess around with wounds so much. So that's why we said we want to have a digital workflow for that. And that is that we would go the following way. We could first give an injection for the patient, and then the patient will wait. Then we use a model, which is a stereolithographic model, a 3D printed model that can be sterilized of the bone, but only of the aspect of the bone we need. And then we will customize the cortical strut on that sterile model in the operation room while we are waiting for the injection to work. So when we will open up the flap, when we do the cut and we open up the flap, it's already customized. We just have to put it into place. We just have to fix it with a screw and do the suture. And so it's a very, very fast way. It's very easy to adjust it outside the mouth. And of course, it's far better to all aspects of infection, messing around with the wound, or keeping the wound open so long. So that's the stereolithographic 3D model, which you can print it. There are a lot of manufacturers now offering material that is sterilizable, and every 3D printer can actually make that. And you can actually make it even shorter because you need only this aspect. So you can order a very small model, which also makes it not as pricey, because you only need the bone aspect to adjust your cortical strut.
Cause you're a sky full of stars. I'm gonna give you my heart. Cause you're a sky, you're a sky full of stars.
Okay, and we'll see then another video. If you do that outside, how easy it is then, even in severe augmentation cases, to fix it. So you see, if it's all prepared, then it's easy to just, even severe cases, place the blade, which is already customized, and just fix it with screws, here in a bicortical case. So even in these cases where we need two cortical blades, see, to reconstruct the inner cortical line and the outside cortical line, to reconstruct a huge vertical loss. This is easily possible, of course, if all these blades have been customized outside the mouth on a sterile model till we're waiting for the injection to work. So in all these cases, you will see that it's easy to just augment the cortical bone to build a container and to get a reliable result of a very stable bone, which is has a slow turnover, and therefore it's not resorbing too fast. It's very vital on the inside and very stable on the outside. It's easy to build in any case of dimension, as long as you can cover it with soft tissue. And with some techniques, unfortunately unknown, in most indications that seem to be difficult, it's actually easy to cover with soft tissue. What are the complications? Now, of course, complication in bone augmentation we've been knowing for decades. So we know, of course, that bits of bone stick out. In this case, probably because we didn't soften enough the edges, in case there was too much tension on the soft tissue, which we did not release. So, of course, it may be a complication used by the colleague, in this case by myself. But interesting, what happens? It's like a good friend. You only know that a good friend is a good friend if he's there in bad times. In good times, every augmentation will work. Here you see that it's exposed. We try to open up in order to contour it. And the interesting thing is that I just could touch this and this came out. And you see that the body actually separated the bone where it sticks out. So where it wasn't nourished, it was just separated by the body itself, like a sequester. You all know sequester when you extract teeth and you have a sequester and it will pop up out of the tissue and you just pick it away. And that's the same thing here. You will have a sequester, but the rest is not harm the augmentation. If this would be an uncovered membrane or if this would be granular tissue, it would be all gone. So in this case, we're just taking out the piece and then we just did some soft tissue adjustment. And in the case of complications, we will grind and remove sharp edges or take away any kind of sticking out bone. We will rinse that with Rivanol H2O2 mixture once a week for 6 weeks till soft tissue closure. And then, of course, in re-entry, we can still optimize the soft tissue then. But very interesting in this case is, you see, that has been the case before augmentation, very thin at the top again, typical severe settle firm defect. And after augmentation, see, that's the reopening. You still got the good augmentation. We got a wide bone. So despite there has been a complication in the opening of wound, we still have a stable condition. So that is also reliable even in cases of complications. Of course, there are complications, but you can handle them. And so we could still place the implants and the implants are still stable in place. So you see that the bone has not harmed and the augmentation has been taking place without a loss that we could not place an implant and no need of re-augmentation. So the protocol actually is that we will use bone particles, autogenous or allograft particles. We will cover it with a Jay's membrane because it's a very thin membrane. It's stable for months, so it's nice protective. And on top, to give it a boost for the wound healing or to improve the soft tissue healing in cases of bad soft tissue because of genetic reasons, because of disposition, or because of smoking else. We use LPRF to make sure that we have a good wound healing. So the cortical struts have a slower turnover, but this seems to be of an advantage. It reduces the resorption. The quantity is not limited. Whenever you need a bone, you can make it full jaw. If you need 2 or 3 plates or 2 plates, you will have them handy and you have them in stock if something happens. So whenever you need to reconstruct something, you will have a piece of bone ready. It's a plug-and-play solution, and even if you use the printed, 3D printed sterile bone models, it's so easy to prepare at your chair with no stress handling, falling off, or if you have a bad assistant, for example. So this is very nice to do. It's a very controlled situation. You reduce trauma and treatment time if you have no second surgery and everything is prepared. It's indicated for all kind of bone augmentation. So you have a vertical, a horizontal. You can put it even in a sinus floor to build a new bony heaven. It's nature identical reconstruction because with this augmentation procedure, we'll get a cortical barrier. So this is my personal email account. In case you have any further questions, me or my colleague will of course answer your questions on emails if we can't get them answered on the webinar now. So this will be the jk@whiter.dental, where we can give you some answers. Of course, if you have answering now, we will be charmed to answer your questions right now. But thank you for listening, and now I'm happy to answer your questions. So, first question is from Valentin Petrov. What bone quality do you get in augmented site, and what torque you get with Ankylos implant in struts augmentation site? Well, the bone quality we get is it's about a D2 bone, I would say. It's not as soft as a D4 bone, which is good. It's about a D2 bone. The Ankylos, I try with all my implants not to get more than 30 Newton centimeters, because I don't want to stress bone too much. I can load implants immediately. If I can load implants immediately with 30 and 35 Newton centimeters insertion torque, why should I get more to have more risk of stress on bone? So that is my personal protocol. Jason Larkin, yes, thank you very much. I'm honored. Okay, then I would like you for your kind attention. I hope to hear from you soon in case you're interested in the technique. And thank you very much for spending your valuable time with me, to all the colleagues in the webinar room. Thank you so much.
We would like to thank our speaker for sharing his knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.